Okay, good evening. My unfolding case study is on the effects of overdose. We have an adolescent named Nicholas Shea, a 17-year-old male. He arrived in the ED via EMS with a suspected accidental overdose. He's unresponsive, and his mother's at the bedside, and so she gives us some background on Mr. Shea. She says that he went partying with his buddies and she was waiting up for him because he was out past curfew. She fell asleep on the couch, and when she woke up about an hour later, she noticed that he wasn't in the house, and so she looked out the window and saw that his friends had left him on the porch and left. So she said he left a note stating he had taken drugs. So that's how we were able to kind of get an idea of what was wrong with Mr. Shea. She said she then called 911 and EMS brought them to the ED. Prior to arriving at the ED, the patient was given 0.4 milligrams of naloxone, and the mother says that she does not know how long her son had been laying there. The nurse goes into the room to collect her assessment to assess the patient. He is unresponsive. She checks his eyes and his pupil to pinpoint with no spontaneous eye movement. She does a sternal rub, and that makes him open his eyes. As soon as she stops that sternal rub, he just goes unresponsive again. She checks his vital signs. His temperature is 101.2. He's febrile. He is bradycardic with a pulse of 54. His respirations is 6. He's breathing real shallow. His blood pressure is low, hypotensive, 89/67, and his oxygen is 88% on room air. So oxygen administration is initiated, and this is a bag valve mask with supplemental oxygen. This is the mask that they use for drug overdose patients. Um, it delivers 15 liters of oxygen per breath. Also, they put continuous pulse ox to Mr. Shea to monitor his O2 stats, and they're going to get some labs drawn along with blood gases. This is the Placebo Opioid Induced Sedation Scale, POSS. This is a scale that is used to rate the orientation of a patient that has overdosed. I have found this in the Pearson book on page 171. This is how they determine how much the patient is sedated. The nurse continues her assessment on Mr. Shea, and on the POSS scale, he has scored a 4, which is little or no movement with physical stimulation. She listened to his lungs and found that he had some wheezing with breathing. And then 2 hours later, on reassessment, he was scored as a 3, which he could be aroused but would drift back to sleep, like in mid conversation. And then his lung sounds were diminished at the bases. After the labs were drawn, they checked the chart and they got his lab values. They did a complete blood count with the white blood cells being 13,000 per microliters, which signals an infection. His hematocrit was 39%, and his hemoglobin was 9.2 grams per deciliter. This could signal poor calories intake due to a lack of balanced diet. Usually opioid dependent patients have suffered from malnutrition. His creatine kinase is elevated at 170 units per liter. I think the highest is 170 units per liter. Creatine kinase is an enzyme that's found in your skeletal muscle, in your heart muscle, and your brain. And when any of those muscle tissues are damaged, the creatine kinase can leak into the bloodstream. And being that Mr. Shea has overdosed, more than likely he has damaged his heart muscle. And so this could be a reason why his creatine kinase is elevated. Also, they did some arterial blood gases. pH was low, so he's acidic. His PaCO2 is elevated. His bicarb is normal, but his oxygen is 88% on room air. So it looks like he has some acidosis going on, some respiratory acidosis. Some monitoring values that we're monitoring is when they place the patient on continuous pulse ox, monitor his O2 stats because it was 80% on room air. Its respiratory rate will be monitored because it was 6 breaths per minute, and his heart rate, he will be on telemetry to monitor his heart rate because it's low, 54 beats per minute. We have some questions. Our first question, based on the client's vital signs, indicate whether the interventions are essential or non-essential. We got the acetaminophen, O2 administration, aspirin, IV fluids. The acetaminophen is essential for his temperature. O2 administration is essential because he's 88% on room air. Aspirin is non-essential, and IV fluids are essential. To keep him from being dehydrated, and sometimes it can help the blood pressure, raise the blood pressure. This is the rationale for the question. Like I had said, the acetaminophen is to reduce the fever, IV fluids to prevent dehydration and to help raise the blood pressure, and O2 is needed for him to improve his O2 sats because it was 80% on room air. Question number 2, based on the assessment data, what could possibly be a complication of the drug overdose? Respiratory acidosis, compartment syndrome, metabolic acidosis, pneumonia, atelectasis, pulmonary edema, and pressure ulcers, which will be respiratory acidosis, compartment syndrome, pneumonia, and pulmonary edema. The rationale for question number 2, the drug overdose, it can cause injury to the lungs, which can cause respiratory acidosis, which is evidence of his pH, which was below 7.35, pneumonia, and also pulmonary edema. And that is evidence of his wheezing that the nurse heard on when she auscultated his lungs. Compartment syndrome, this can happen due to a drug overdose because of the way Mr. Shea was laying and for how long he was laying on his extremities for an extended period of time, because it blocks the blood to go to the nerve cells and the muscles. That's why compartment syndrome can be a complication of drug overdose. This is question number 3. If the mother had not been at the bedside to give the nurse the information of the note saying that Mr. Shea had taken drugs, what action would the nurse have taken? Try to find out the patient's identity, check the patient's blood glucose, call the provider to see what they would recommend, and do nothing and wait for the patient to wake up, which the nurse would check the patient's blood glucose. This is the rationale for question number 3, because checking the blood glucose would make sense because a very low blood sugar can cause a diabetic patient to be comatose. And if we didn't have the information that the mother provided about her son taking drugs, we could assume that maybe he was diabetic, and that's why we would check the blood sugar to see if it was low. We're on day 2 of Mr. Shea's admission. The nurse comes on shift and receives report on the patient from the night shift nurse. She tells the nurse that he has been diagnosed with pneumonia and compartment syndrome, which is caused by the patient while he was lying on his extremities for an extended period of time, which can cause swelling of the extremities, as you can see here, and it's got a discoloration to it. The patient goes in to see Mr. Shea and to do her shift assessment. She sees that he's not unresponsive now, but he's still drowsy, but he's easily aroused. And so he scores a 2 on the POSS scale. She assesses his breathing, which is even unlabored. His capillary refill is less than 4 seconds, which is abnormal. Should be less than 2. He has mild tinting of the skin, which can signal dehydration. She checks his vitals. He still has a fever. He's still febrile, 99.0. Still bradycardic, heart rate of 58. His respirations are still abnormal at 10. His blood pressure has increased a little, 96/60, but he's not out the woods yet. His O2 is 92%. That's better, but it's on 2 liters of nasal cannula. They're still monitoring him on the continuous pulse ox, so we can continue to monitor his O2 sats. They're still monitoring his respiratory rate, since it's still low, abnormal, less than 12. And also he is still on telemetry to measure his heart rate. So we're checking his lab values again. White blood cells, they're still elevated at 12,000. Creatinine kinase, still elevated. Well, 169 units per liter. The max is 170, so it's still high. His arterial blood gases, pH has gone up to 7.35. PaCO2 is 45, and his bicarbonate is 24. And his O2 is 92%, 2-liter nasal cannula. His medication and treatments that has been ordered. We have naproxen, reduces swelling, antibiotics for his broad spectrum antibiotic for his pneumonia. Also, albuterol bronchodilators. They dilate the bronchioles to expand his lungs so he can breathe better and we can get his oxygen up. Acetaminophen is for pain relief. Being that his temperature is a little better, 99.0, and also oxygen therapy still. Alright, question number 1. Which task below can the nurse delegate to the UAP? Perform neurochecks on the patient, measure and record intake and output for the patient, adjust the patient's oxygen level, or administer the patient's PM medications. Here we have the rationale for question number 1. The answer was to measure and record the patient's intake and output because this is within the scope of practice of the UAP. The other questions were out of the scope of practice. This is question number 2. The UAP enters the patient's room. His oxygen is not in his nose and he is acting confused. The UAP should blink because blink causes confusion. The UAP should replace the oxygen because lack of oxygen causes confusion. This is the rationale for question number 2. Lack of oxygen can cause confusion in some patients. So if your patient is alert and oriented before he takes his oxygen out, then when you go back and he's acting confused and you see that the oxygen is not in his nose, then that's likely the culprit of why he's acting confused. So just go ahead and put the tubing back in his nose, and then he should be more alert and oriented. This is question number 3. The patient that has suffered an overdose is completely immobile, is at risk for pressure injuries. What is the interventions to prevent pressure injuries? Turn the patient every 2 hours, pad the bony prominences, increase the patient's fluid intake, add protein to the patient's diet, insert a Foley catheter, keep the patient sedated. This is the rationale for question number 3. The interventions for a person that is immobile is to turn the patient every 2 hours. We should pad the bony prominences and increase the patient's protein in their diet. Protein promotes healing. So that's why it is good to incorporate protein into a patient's diet. We are now on day 3 of Mr. Shea's admission. The nurse comes on shift and gets report for the patient. She goes into the room to do an assessment on Mr. Shea and notices him sitting up, talking to his mother. She assesses his breathing, his respiratory rate, his breathing even in unlabored. She scores him on the POSS scale as of a 1. He has no tinting of the skin and his capillary refill is less than 2 seconds. So this indicates that he's getting good perfusion to his tissues. His lungs are clear in all fields. His vital signs are normal and he is on 95% on room air. The monitoring values that we're going to monitor, he's no longer on continuous pulse ox. His respiratory rate is normal, 12 beats breath per minute, and his heart rate is 62. He's still on telemetry though. The nurse is reviewing his lab values for day 3. His white blood cell count has came down to 9,000. His creatinine kinase is good at 150 units per liter. She checks his arterial blood gases. pH is 7.35. PaCO2 is 45. HCO3 bicarbonate is 24 milliequivalents per liter, and he is 95% on room air. So his labs are normal. So that should indicate that he is improving and getting better. Mr. Shea's medication and treatments for today is acetaminophen for if he has a slight fever or any pains. Albuterol, even for breathing treatments, and his antibiotics, because we want him to finish his antibiotic regimen, because when you have antibiotics ordered, you should take all of the antibiotics until they're gone, and do not stop them because you're starting to feel better. Question number 1. The client is more alert and oriented and asks the nurse, could he take a shower? What is the most appropriate response by the nurse? I don't think that would be a good idea. I will have to contact the provider, ask the UAP to assist the patient with a shower, and check the patient's chart to see if it's okay. This is the rationale for question number 1. Since the patient is alert and oriented, it's fine for the UAP to assist him in the shower. Just she has to make sure to wrap his IV up so it won't get wet, but it's fine for him to take a shower. Question number 2. The patient is getting ready to take a shower, but he has an order for continuous oxygen monitoring. What can the UAP do to enable the client to shower? So he has to continually have his oxygen on. Tell the patient to wait to shower at a later time, get an extension tubing from the supply, remove the oxygen, and let him take a shower without the tubing. Tell the patient that he will have to have a bed bath. Just tell him that you will be back and don't return because you don't have time for that. Inform the nurse that the patient needs longer tubing. Ask for assistance from another UAP. This is the rationale for question number 2. The UAP can just get an extension for the patient's tubing from the supply room. This way, the patient can continue to have his oxygen tubing in his nose and it will reach to the bathroom for him to take a shower. It is not protocol or professional for a UAP to tell a patient that they're going to go get something or ask a nurse something and then just don't go back to where they're at because they don't feel like dealing with it. That's not what you should do. And if the patient is able to get up, it's better for him to go ahead and get up and get moving, clear those lungs out. Question number 3. Patient requires another IV because the one in his left forearm has become dislodged, probably from that shower. But the nurse delegates to the UAP to remove the IV because it is in their scope of practice. This is the rationale for question number 3. The UAP is allowed to remove an old IV. Just need to make sure that when they are taking the tegaderm off and they pull the IV out of the patient's arm, they need to inspect the catheter to make sure it's intact. If it's broke off, then that could be a signal that the piece of it is inside the patient's skin. We are finally on day 4. Mr. Shea is getting discharged, so the nurse goes into his room and performs her assessment on Mr. Shea. She notices that his breathing is even in labor. That's good. He scores 1 on a POSS scale. That's good. His skin tension is 0, and his capillary refill is less than 2 seconds. This is all normal values. His lungs are clear in all fields, and he denies any pain. The nurse is checking his vital signs, which are all normal. They're within parameters. His afebrile, his heart rate is within normal, respiratory rate is normal, and blood pressure is normal. It's really good. And his oxygen sats are really good at 100%. He is no longer on continuous pulse ox. His respiratory rate is good, breathing even unlabored, and he is no longer on telemetry. The nurse checks his lab values to make sure they're still good, and they are. White blood cell count's good, creatinine kinase, arterial blood gases, pH, PaCO2, bicarbonate is really good, and his O2 sats 100% on room air. This signals a really good recovery, and he is ready to go home. The nurse is reviewing his medications and treatment. The provider has written some prescriptions for the client to be discharged with ibuprofen, penicillin, and prednisolone. And like I said, the antibiotics, you need to finish those, the whole regimen, and don't just stop taking them when you feel better. Ibuprofen can be if you have any little pains, and the prednisolone is still for his bronchioles to dilate so he can get enough oxygen to his lungs. It's time to discharge Mr. Shea. The nurse goes to his room and she educates him on the effects of overdose and also gives him and his mother some information that they can read about on their own. She also teaches them about the medications that the provider has prescribed, the antibiotics he needs to take, the whole regimen, and don't stop because he's starting to feel better. About his ibuprofen for pain relief and his prednisolone for his breathing to open up his lungs, expand his lungs so he can get good oxygen to his lungs. Question number 1. The nurse is educating the client on the medications that the provider has prescribed. Which statement made by the client indicates an understanding of the teaching? I can stop by taking my antibiotics as soon as I start feeling better. I must complete my antibiotic regimen. If my relative needs some antibiotics, I can give them some of mine since I have plenty. There is no expiration for my antibiotics. Rationale for question number 1. Once again, the patient should take all the antibiotics until they are gone, not till they feel better. Question number 2. Indicate whether the interventions below are essential or non-essential to discharge of the patient. Educate the client. Ensure client has a ride. Ensure client understands teaching or client's marriage status. We need to educate the client on the medications, their diagnosis, what to look for, the symptoms to report if they have them. We have to ensure the client has a ride, and we have to ensure client understands the teaching. We can do that by return demonstration, or if there's nothing to demonstrate, if you're teaching them just like about the medications, they can just repeat to you the side effects of the medication and what to look out for. Client's marriage status, we don't need to know prior to discharge. And I answered it under non-essential, but my little circle is hiding it. The rationale for question number 2. It is the responsibility of the nurse to ensure the safety of the client. Client safety is number 1 priority, and we have to ensure their safety, and so that's why we need to make sure they have a ride before they try to leave. And the client's marriage status is irrelevant to the discharge. Question number 3. The client is ready to be discharged, and he asks the nurse, could she push him down in the wheelchair? What is the appropriate actions by the nurse? Take him down in the wheelchair, contact transport for them to come get him, have the UAP to take him down in the wheelchair, tell him he can go down by himself. This is the rationale for question number 3. When a patient is discharged from your unit, from the floor, the proper protocol to follow is to put a order in for transport. The transport will come to your floor and get the patient and bring a wheelchair if they're ambulatory, and get a wheelchair and take them down. If the patient is bedbound, normally the EMS comes to pick them up and takes them out. And this is my last slide that contains my references that I have gotten my information from, my lab results, my definitions of what the compartment syndrome consists of. I use Pearson and ACI, and then I have 2 peer-reviewed articles that I found that are less than 5 years old.